Okay, so good morning, everyone.
Good morning.
My name's Kelly Sweeney McShane, and I'm the President and CEO here at Community of Hope, and it's my great honor to welcome you all to Community of Hope in our Conway Health and Resource Center. We are really excited to host this announcement about the Right Care Right Now initiative, and we feel that it's very appropriate that it's held at a community health center here in Ward 8, where we're providing primary medical and health care to residents of the District of Columbia. For a long time, the district did not have enough community-based primary health centers throughout the district, and we do now, that there are beautiful facilities all over the city that have been funded over time by the city. Today, patients have places to go, beautiful, affordable medical homes providing a high quality of care, such as this one, right in your own neighborhood. Community of Hope, along with our fellow community health centers, is pleased to be a partner with the city on Right Care Right Now. I'm proud to say that Community of Hope is ready. Our services are ready. We provide a full range of medical, dental, and behavioral health services at 3 health centers across the district. We're already a medical home for almost 11,000 patients that we served in 2017, over half of which live in Ward 7 and Ward 8. So what does it mean to be a medical home? It means that our patients have trusting relationships with their providers. It means that our doctors and our nurses know our patients, their health history, their medication, their challenges, and their successes. All of our staff can provide assistance, whether it's questions with insurance, helping to make an appointment with a specialist, help with diet and nutrition, or education about pregnancy and diabetes. Our front staff greet our patients by name. Patients talk about how they feel like they're home, that we're a family, and in many cases, we're serving generations of patients. Our systems are also ready. More than 1/3 of Community of Hope's visits are scheduled for the same day that a patient calls, so patients can get the care they need it when they need it. We also work to have patients seen within an hour, so they don't have to wait and can move on within their busy lives into the next thing. We've been working closely with fire and emergency medical services to set up the systems so that we can be ready to see patients quickly and that patients have transportation that they need. And we are committed to partnering on this very important initiative. With all of these great services, easily accessible within your own community, why would anyone, if it's not an acute need, wait for hours in an emergency room? I look forward to our partnership and to helping DC achieve health equity and to welcoming patients to our home. Our family is here and ready to care for your family. So now to hear some more details about this initiative, I'm very pleased to introduce a visionary leader that I'm proud to partner with on many different initiatives, including this one, Mayor Muriel Bowser.
Thank you, Kelly. Thank you. Thank you. Well, good morning, everybody. And let's thank Kelly Sweeney McShane again for inviting us to the Community of Hope, a wonderful facility right here in a great neighborhood in Washington, D.C., in Ward 8, and a place where there are caring medical professionals who are here to service the residents of the District of Columbia and get them the care that we need. We are really excited to be here today to talk about a new program that we know will help D.C. residents get the care that they need when they need it, and make sure that our emergency services are being used most efficiently. I am joined by our outstanding chief of the Fire and Emergency Medical Service, Chief Gregory Dean, and we're very delighted that he's here, as well as the medical director for Fire and Emergency Medical Service, Dr. Robert Holman. Thank you, Dr. Holman. As well as our outstanding director of the Office of Unified Communications, also known as our 911 and 311 call center, Karima Holmes. Thank you, Karima, for being here. Our Deputy Mayor for Public Safety and Justice, Kevin Donahue. Thank you, Deputy Mayor, for your leadership on this. And in the audience is another cabinet member, Dr. Tanya Royster, who is the director of our Department of Behavioral Health. So, Tanya, thank you for being here. So I'm not going to say a lot because I'm going to leave it to the chief and Dr. Holman and Karima Holmes to tell you about how we are making our emergency call system more efficient and better so that our residents who need help are getting the right care right now when they need it. We've been talking over the last 3 years about how we are going to make our systems work better. We have put in place a system for less acute calls already, where we're using another provider to help us with that. Using that provider has given us more time and for our personnel to focus on more acute cases and more training. And we've been very happy with that process. We made a promise then that not only would we be looking to make sure that our acute calls and our basic calls were being handled appropriately, but we would work with our communities to actually reduce the number of 911 calls where we can, and to make sure when we are getting 911 calls that our residents are being connected to the care that they need. Frequently, more frequently than any of us are comfortable with, the calls that we get are in fact not emergencies. And those calls are taking up an ambulance and taking up space in an emergency room, when in fact people are calling because they need help. And what we want to ensure is that at the 911 call center, we're able to distinguish between those emergencies and those calls where people need help. They may need a ride. They may need a nudge to get to their medical home, but we are going to put a system in place so that everybody is getting what they need. We know what it means in the end. What it means in the end is that person who's calling with a heart attack is going to have a vehicle available in space in the emergency room. And so I couldn't be more proud of our team at FEMS for devising a plan that's going to work for our city. And I am pleased now to introduce them to tell you more about it. Chief Dean.
Good morning. Thank you, Mayor Bowser, Director Holmes, and Ms. Kelly Sweeney McShane. We have our partners here today, and our partners are our Local 36 President, Dabney Hudson. Thank you, Dabney. And Local 37 President, Aretha Lyles. Aretha, thank you also. But there's a group that we need to thank, and that is Dr. Holman and everyone from DC Health, the Department of Behavioral Health, DC's Department of Health Care and Finance, and so many of our others from across the city associated with medical care, who have proven to be as dedicated as the mayor in ensuring we are doing our best every day to provide the most appropriate and responsible path to improve outcomes for every Washingtonian. The district is dedicated to ensuring that when it comes to health, you receive the right care right now. DC Emergency Medical Services is rolling out this initiative with the goal to improve health outcomes and preserve resources for patients with life-threatening injuries and illness. Tying it into 911, unlike other nurse triage lines in operation across the country, we do not want our callers to guess if they are having a medical emergency. Instead, we want our OUC 911 operators and the newly added nurses to utilize their training and experience to determine the best and most appropriate path to improve health outcomes. The DC Fire and EMS Department has one of the highest call volumes per capita in the country, averaging over 500 calls every day. Many of these calls are tied to EMS, and when many of our members are providing pre-hospital care and transporting many of our low acuity patients to hospital emergency departments, we realize that an emergency room is not always the most appropriate medical setting to address their medical conditions. Our overall goal behind Right Care right now is to link some Washingtonians who may have come to rely on 911 as their source of receiving primary care to an actual doctor in their neighborhood. If successful, it is a win-win for everyone. Many of the low acuity callers to 911 will now be connected to a primary care provider near their home, while our resources will be better positioned to respond to more serious life-threatening cause, providing our members with an opportunity to practice good medicine by providing the most comprehensive and compassionate pre-hospital care, which they're doing every day. It's my pleasure now to introduce Dr. Holman, the one who's kind of the father behind all this.
Thank you very much. I also would like to thank everyone from the Community of Hope for hosting us here, Kelly Sweeney McShane and others. I'd really like to thank Mayor Muriel Bowser for your leadership and your support. Whenever we hit an obstacle, and there were many, we would say, this is a mayoral initiative. And they started to cooperate. So that was very helpful. I hope you don't mind that we used your names. Okay. We had a number of people involved. In fact, yesterday we were finalizing the list count. We counted 160 names. And so rather than read them all today, I'm just going to highlight a few. And so, I must, because these people really worked hard. And I want to thank those from AmeriHealth Caritas, Karen Dale and Stephanie Hafitz, from AmeriGroup, Linda Elam and Jennifer Gerald, from Trusted Healthcare, Tommy Duncan, Anna Millette, and Felicia Sears, our clinical partners at the Federally Qualified Health Centers, the FQHCs, Tracy Harrison, who's here today from Unity Healthcare, Dr. Randy Aberson from Bread for the City, Ingrid Anderson from Mary's Center, Jessica Estrada and Dr. Sarah Henn from Whitman Walker Health, Dr. Ricardo Fernandez from La Clínica del Pueblo, from the Community of Hope, Victoria Roberts especially, and Darby Bree Saunders, and from Family Medical Services Center, Dr. Michael Serlin in Isatu. From GW's MFA's Urgent Care Center, we'd like to highlight the help of James Betts, and from the lab at DC, David Yoakum and Krisanthi Hatsumura and Kevin Wilson. From the Department of Health, there were many. I'm just going to highlight Dr. Nesbitt and her team. And from the Department of Healthcare Finance, Wayne Turnage and his team. There were many helpful people, and I hope you don't all feel so slighted. But I know where the back door is. So, from MSAC, Cynthiana Lightfoot. From AMR, Sam Brown and his team. And from CRISP, Brian Bramble and his team. My background, very ill-prepared for something like this. I practiced in Arlington for 24 years, and things ran very smoothly most of the time. I spent 3 years practicing at Unity Healthcare and serving the underserved, and I was struck very often by the disorganization of the access patterns of my patients. There were too many ER visits, patients were running out of medications, etc. And I thought this was really the system's problem. I had a patient, while I was still working half-time at Unity and working half-time with Fire and EMS, I had a patient who came to see me in the walk-in clinic for treatment of a urinary tract infection. And she said very decidedly, I just want my antibiotic. I was in the ER at Washington Hospital Center 5 weeks ago. I had a UTI then. They gave me an antibiotic. It wasn't such a big deal. Stop asking me all of those questions. But I could see her vital signs, and one of the fifth vital signs was her finger stick glucose, which was not normal. It was 462. And so I gently tried to talk to her about her diabetes, and she said, it's fine. It's fine. And so I sat down and I struck a comfortable pose, leaning forward, nodding appropriately, and said, well, let's talk about that. And she said, again, it's fine. I said, well, when was the last time you went to the pharmacy for your medications? And she initially said, about a month ago. And then as we started to develop a relationship, she said, well, it was about 6 months ago that I last took a medication for my diabetes. I tried to peel that apart a little bit, and finally she said, I'm having flashbacks, and it's so hard to manage my diabetes. Finally, we understood that she was very depressed. Her loved one had been in a nursing home for about 12 years. She was raising their daughter alone in a single room apartment, and she had a lot of distractions. It wasn't her fault. There were all sorts of things about that we could help her with, however. And so, talking to her, I realized there's got to be something that we can put in place to help this individual. She was used to calling 911 for the emergency department. And so, Right Care, Right Launch is going to help this individual should she call 911 again. When I first joined the department about 2 years ago, we had just been launching the private ambulance service with AMR, and we're showing lots of data about our call volume. And I noticed, along with everyone else, that we transported lowest acuity calls still, which made up about 24% of our calls. And when I started to learn what they were, I thought about all of my patients at Unity that seemed to needlessly access the emergency department through 911. After talking to Chief Dean, he said, go for it. So I talked to my assistant Clotilda and I said, let's have a meeting. And she said, okay, I'll put it together for you. We invited 9 people and 26 people showed up. So I knew that there was an appetite. And so it just sort of went on from there. We had a lot of leadership from Mayor Bowser, so thank you. One of the things that we did is we looked at where our low acuity callers were coming from. And we did a geospatial map which showed points with big towers and then other smaller buildings, but there was a lot of clustering of our lowest acuity callers east of the river. And then when we studied, where are we going to have these patients go, we looked up the system of federally qualified health centers. Actually, it was Dr. Nesbitt who suggested that we should have a certain criteria for our clinic partners. And in fact, we went from a list of 200 down to about 16 or 18. And then we looked at where they were. And they exactly dovetailed with where the patients were calling from. And I thought, how fortunate. But of course, that's why the clinics are here, because they know the individuals and the communities they need to serve. So what we're going to do is we're going to serve these low acuity callers, and how we're going to do it is we're going to have the 911 call taker use the algorithm that he or she ordinarily uses, which will already sets up a triage system. We're going to add a nurse triage line choice to that, and then for those appropriate callers, send them to the nurse who's going to do the triage work. That individual will get a secondary telephonic triage by a nurse whose experience and training is in this kind of work and knows even better than the 911 call taker how to do this triage. Once that triage is done, the nurse has available a list of clinics and with individual sessions and capacities for each clinic site. We're now up to 23 sites that we'll be sending these patients to. She'll also have the advantage of being able to select a transportation vendor for about 70% of those callers, because actually, through one of the statements that Mayor Bowser made at one of our meetings, we realized that there was the Medicaid, managed care organizations, and Medicaid itself had transportation monies, but we just needed to shift those efforts from more than 3 days out to same day urgent. So for most of our callers who go through the nurse triage line, they'll actually be sent a vehicle to pick them up right away. And they'll be picking them up within 30 minutes, and at the very, very latest, it'll be an hour. But we really expect most of them to be within 15 minutes. They'll be taking them then to one of our clinics, and they'll get comprehensive care. And for those who've been taken there by a vehicle, they'll have a number to call when their clinic visit is over, and they'll have a ride home. And so we're really excited for all of that. This is a big effort with many people involved. We're going to ramp this up very slowly. We're starting at 65 calls a day. We're going to be looking at all of the wrinkles and the bugs, fixing them, and then be able after 6 months to launch up to 130 calls and then even more later. We will be doing a very careful analysis to see whether we actually can affect the way these callers are using healthcare. Are we going to be able to actually have them see less of the emergency department and more of the primary care centers where they'll receive comprehensive care? I think there's a real big picture, as the mayor pointed out, to Washingtonians in general and our department and those whom we serve as this Right Care Right Now is launched. Thank you very much. Oh, one more. And so for getting all the pieces together, to make this idea a reality, this would not have been possible without the cooperation of the Office of Unified Communications and Ms. Karima Holmes and her incredibly talented and willing and hardworking staff who were able to pull this all together and set this implementation up. So, Ms. Karima Holmes, thank you very much.
Good morning. Thank you, Dr. Holman, Mayor Bowser, Chief Dean, President Sweeney McShane, for hosting this event today. As you may already know, DC 911 is one of the busiest call centers in the country. Last year, we answered 1.4 million calls for service. Of those calls, 19% were medical calls for service, and many of them were low acuity and did not warrant an emergency response. As Mayor Bowser has stated, 911 should only be used for serious emergencies. But we know that many callers may not be aware of other avenues for getting the medical care that they need. For this reason, the Office of Unified Communications, DC 911, is pleased to support Right Care Right Now. This initiative, because we believe it is an innovative step forward in reducing our non-emergency call volume. I'm confident that my staff is more than prepared to embark on this new initiative. In fact, for the past several months, my Office of Professional Standards and Development has tirelessly trained our 911 call takers and dispatchers by going over medical scenarios and offering intensive training to best approach this launch. When a call comes into the 911 center, our operator will ask questions about the caller's medical symptoms, just as we do today. And together with our computer dispatching system, we will make the determination on whether the call should be transferred to the Right Care Right Now nurse triage line, which will be available every day, 7 to 11 p.m., 7 a.m. to 11 p.m. If not, it will be handled in the traditional way we do today. In any case, I assure you that the OUC is prepared to handle every call appropriately and with the highest level of customer care. We welcome the nursing staff to our center and look forward to our work on this important collaboration. The Office of Unified Communication is proud to serve as a community partner in helping the district residents on the path to improve health care via Right Care Right Now. Thank you.
Okay, I know you have a lot of questions, so I'm going to make sure my team is available. The Deputy Mayor will be available for questions as well. Chief and Dr. Holman and Karima, if you would come towards the podium. Any questions? Oh, maybe there aren't any questions. Yes, Paul.
Excuse me. Where are these nurses coming from? Are they all RNs?
Let me have Dr. Holman talk to you about how we are contracting to make this happen.
Thank you. The nurses in the OUC will be RNs with emergency experience, so they'll know exactly what it's like to triage a patient. They will have backup off-site by other nurses as well.
Probably Chief can answer this. As far as AMR is concerned, the city is spending millions of dollars for AMR. I imagine these calls are going to cut down on AMR service. Is that going to save the city some money, or are you going to reduce the number of AMR ambulances out there?
Well, first we're going to see how this works. We are in the first several months, and I'm going to ask the Deputy Mayor to speak to this, limiting, so not all eligible calls for nurse triage are actually going to be sent to nurse triage in the early months so that we have some time evaluating how the system works. And I expect that after 6 months, we'll be able to look at the call volumes, at what calls are being transferred, how effective we think it is, and then the chief and the deputy mayor can make any adjustments from there.
As Dr. Holman mentioned, the volume of calls that would qualify for this are north of 200. Now, on day one, we are not going to start with that number. We're going to start with 65. So over the course of looking at the 65, as Dr. Holman said, it is in part meant to make sure we work out any speed humps we come across operationally as we roll this out. It also gives us a chance to naturally evaluate those who are going to the nurses and those who qualify, but because we're limited to 65, we're transported to an ER traditionally. And that way we can look at ER utilization, we can look at primary care utilization, and for those who are part of the Medicaid system, we can really look at the quality of health outcomes that the individuals get who are going to the nurses. Now, with 65 calls a day, it may not make an appreciable difference on ambulance rides, but when this works and we ramp up to 200 or more a day, then we'll really start to see an effect that we have on the level of need for low acuity calls going to ERs.
Yes, sir.
Question for the chief and for the medical director. Can you demand an ambulance if you're convinced you need one and maybe not able to explain that, or are you going to have to go through sort of a phone maze?
If you're going through a phone maze,
Are you going to get pawned off on someone else? Let's say you
no one's being. What is your name?
John Aaron from WTOP.
Okay, no one's being pawned off on anything. What we are doing is, and you've heard the explanation of what our qualified call takers are asking questions, because that's what happens when you call 911. If our system determines that it is a nurse triage eligible call, then they will go to the nurse triage, and the nurse will help walk them through their issue. Anything else you want to add?
Sure. So what we have right now is a system, and I'll be bold, I'll just say that sometimes we don't practice good medicine. Taking patients with a sore throat or a bladder infection to the emergency department where they interfere with the care of more acute patients and they're not delivered to the site where they're going to get better care, to a primary care site, I think is bad medicine. And so when we have individuals that are going to say, but I've always had an ambulance for my sore throat, we're going to say we're going to get you to the right place right now.
In the same vein, something that a nurse would have to triage, let's say a toothache, which, as you know, could be something like a heart attack. Are you worried that something could slip through the cracks like that?
So our nurses are trained with their nursing, with their algorithm, with their emergency experience, that they'll know that a toothache would not be a heart attack unless there's something extraordinary going on.
Possible symptom.
Sir, but they would ask all the other possible symptoms of a heart attack and the risk factors and the clinical background of the patient, so they would know whether this is someone who would be at risk. So usually those toothaches are just toothaches, and those individuals would be going to the clinic where they should go.
Any other questions? Yes, sir.
The vehicles that are coming to pick up these people, this is from where? Is this a Lyft or Uber? Or?
Sure, I'm going to ask the doctor to say a little bit more about that. But you heard already the partnerships we had with our Medicaid providers, and a predominant number of calls that we're getting that right now are being transferred to that are BLS calls, and the doctor can speak more specifically about numbers. So our Department of Healthcare Finance is helping to arrange rides. We have a number of providers, and you can talk to all the ones who have signed on, Doc.
Okay. So we have for Medicaid, pure Medicaid, there we have four different types of Medicaid in the district. We have 3 managed care organizations and 1 what we call fee-for-service Medicaid. For fee-for-service Medicaid, they will use a transportation vendor called MTM, and they will be using Lyft vehicles. The other 3 types, the managed care organizations of Medicaid and DC Healthcare Finance patients, they'll be using a different vendor called Access to Care, but they'll also be using Lyft vehicles in case there's a wheelchair need, and then each of those will be using taxis or yellow cabs. The percentage of low acuity calls that have those kinds of insurances and will be eligible for transportation is 70%.
Thank you, everybody. Well done. Oh, I'm sorry. One more thing.
So we're going to move the podium and do a 60-second video. Is that a video? Yes, you're welcome. Yeah. I'm Gregory Dean, Chief of the DC Fire and EMS Department. When you call 911, it's for an emergency. But not all medically related 911 callers are best served by an ambulance ride to a hospital emergency room. That's why we're adding a nurse line to the district's 911 call center, so we can get you the most appropriate care for your symptoms. With this service, a nurse will connect you to a community clinic that will be ready to treat you. If you're a Medicaid beneficiary, we will also provide free, non-emergency transportation. Remember, if you are suffering from minor illnesses, like a common cold or virus, a sore throat, or a minor cut, you should see a primary care provider. If you think your life is in danger from a more serious illness or injury, please call 911. We look forward to getting you the right care right now.